it's probably not standard procedure for neurosurgeons to be worrying about gene testing on the P450 microsomal enzymes. But when dealing with these unusual genetic diseases, we've found that almost every patient has a deficiency of the enzymes that degrade and metabolize the drugs that we give them. And so in caring for these patients, we've found that it's really necessary to start doing this DNA testing. And there are a number of companies around, but Genelex, which is based on the West Coast, is a very, I think, high-integrity firm that really gives great service to the patients. My wife was with me when we first heard this talk at a meeting. She thought it was the most important talk she'd ever heard. So I wanted to invite Dan here because I think this is something we all need to know about and maybe lead the medical community in how we look at this problem.
So thank you, Dr. Henderson. I appreciate that very much. Very quickly, at the end of your presentation, you talked about this cave drawing with this man wrangling this snake. And I feel like cytochrome P450 testing is one more snake that we're going to throw at you in the sense that it's just one more thing of all these things you have to deal with. You have very complex patients dealing with all sorts of problems. And this is one more. The good news is this is a snake you can wrangle. Our lab will help you do that. So I don't want you to feel daunted when looking into this lecture. Hopefully, by the time it's over, you feel like this is something you can have some control over. So I've been employed by Genelex and Uscript since 2006. My background is in account management and social services. My day-to-day operations are outreach to patients and physicians discussing pharmacogenetics. Pharmacogenetics is just a big word for medications with genetics. That's all that means. A quick thank you to Dorothy and Caitlin for arranging this and allowing me to be here. The Coalition Against Pediatric Pain introduced our lab to Drs. Henderson and a few others, and Dr. Henderson has introduced us to CSF. So I just want to mention that reciprocal relationship that we appreciate. And then Drs. Posinki and Afrin helped out along these lines as well. So we'll review the most clinically significant cytochrome P450 enzymes and why they should be in mind at the time of prescribing medications. Then we'll look at them specific to the Chiari hypermobile and EDS population. And then finally, implementing the testing in your practice. So the first question is DNA and adverse drug events. This is Michael. He's the reason our lab is in existence. Michael died from a seizure caused by chronic fluoxetine overdose. At the time, in the 1990s, our CEO had read about Michael, and we were a forensics lab. We were not doing anything regarding cytochrome enzymes or health-related testing. And Michael's story is pretty sad. He had foster parents who were accused of poisoning him to death with Prozac. It went to court, and they got a second opinion from a second medical examiner. The second medical examiner, fortunately, knew about the cytochrome P450 enzymes, and post-autopsy had him tested for 2D6 and found out that Michael didn't make this 2D6 enzyme. So while he was taking Prozac, it had no way to leave his body, and the drug was accumulating in his body to the point that it created toxicity to the point that Michael died. 2D6 is the major metabolizing pathway for fluoxetine for Prozac. So if someone doesn't make that enzyme, they're going to get into trouble with the medication at one level or another. Obviously, his doctor would have changed Michael's medication or dose had he known. If Michael had been given Zoloft, he probably would have been therapeutic on Zoloft because it doesn't use the 2D6 enzyme. So DNA and pharmaceuticals. These are really numbers you want to remember. 60 to 75% of all medications are processed by genetic-specific enzymes. We talked about a couple of them today. Pindolol is a 2D6 enzyme medication. Midodrine is a 2D6 medication, and we're going to go into a lot more, but that just gives you an idea. So more than half the time, 50 or 60 to 75% of the time you prescribe a medication, it's going to be dependent on enzymes that have a great deal of genetic variability from one person to another. More than 75% of the population has genetic variations that increase the risk for adverse drug events. So when we say more than 75% of the population, that means everyone in this room. It means everybody, period. It's not just a specific subset of patients. This can be the case with anyone. It's passed down from mom and dad, and I'll get into that shortly. And the tricky thing about this is the medicines most commonly associated with adverse drug reactions are 8 more times to use these pathways. So these enzymes we're looking at testing, these 5 enzymes, are really the troublemakers. And this is, very importantly, it's exacerbated by polypharmacy. If you're only taking one medication, it's not as likely that you're going to bump into this problem. But the average EDS hypermobile Chiari patient is taking 10 medications, which means there's a high probability that they'll bump into this problem. So pharmacogenetics is just the understanding of how genetic variability alters drug response. The cytochrome P450 enzymes, that's just a big word for a lab-developed test, and I wish it was, there was a more marketable term for that because it's really easy to get daunted by that word. But that's all it is. It's cytochrome, or shortened for CYP. These are the metabolic factories in the liver and intestine where these enzymes are basically made by the body. Think of these cytochrome enzymes as highways for drug metabolism. Genes, this is important, genes, over-the-counters, herbals, and other drugs can change these levels. So you've probably told your patients before, don't drink grapefruit juice while taking this medication. That's an example of essentially that happening. So there's a lot of other drugs on the market that can also affect these levels while the patient's taking them. And you know, this is medication, how we've been sold medication. One size fits all. We can prescribe one medication to everybody. This is not the way to think about medication anymore. This is not the right way to do medicine. As we've heard today from multiple folks, no one patient is the same. Every patient is different. And life would be easy if everyone was the same, but we wouldn't have jobs to do if that was the case. So the fact is, people vary with how much of this enzyme they make. Some people are fine on a normal dose as made by the pharmaceutical company. Other folks need half that dose approximately. Some need more, a higher dose, and some shouldn't be taking certain medications at all, as in Michael's case. So looking at the costs associated with adverse drug events to give you an idea of the scope of this, according to the FDA, conservatively, $30 billion yearly spent on adverse drug reactions in general, so not just drug-gene interactions, but just adverse drug reactions in general. And they say, worst case scenario, we're spending up to $136 billion a year on this. So it's a major issue. We know that it's costing us money, and it's also something we can start getting our hands around. So the next question is then, knowing how much money we're spending on it, how common are drug and gene interactions? And we found that drug-drug interactions account for about 66% of interactions. Drug-gene interactions, where you have a drug and a gene component where there's an interaction going on, account for about 14% of adverse drug events. And then drug-drug gene interactions, this is where you have a patient taking, say, who's already an intermediate metabolizer, making less of the enzyme than normal, who's taking a drug dependent on that enzyme, who's then taking another drug that's further inhibiting that enzyme. That's a drug-drug gene interaction. Account for 19% of interactions. So 34% of adverse drug reactions approximately happening out there have a genetic component, and that's what we're going to focus on today. The FDA is keenly aware of this. There's more than 100 medications on the market that have gene-drug interactions identified on the FDA product insert. Many of them have black box warnings like codeine. They recently put a black box warning on codeine, suggesting that children who are ultra-rapid metabolizers for codeine have more likelihood of death because they make so much of the active metabolite morphine, so much of that hits their system that it can cause death. They've also seen this in mothers who are ultra-rapid metabolizers who are breastfeeding their children. The mother has so much of the active metabolite of codeine, morphine, coming through her breast milk that it can be fatal to the child. So these are known issues, and it's, I'm not going to go into all the study data because I have a lot to get to today, but if you want to look into this more, it's all out there on the internet. There's a lot of good data out there. Just a quick idea of how this is passed down. So this is a typical kind of family tree. This shows the plus sign means a functioning allele, and the minus sign means a non-functioning allele. If both parents have functioning alleles, then they're what we call normal metabolizers, and all the kids are guaranteed to be normal metabolizers. If both parents have two non-functioning alleles, we call them poor metabolizers, all the kids are guaranteed to be poor metabolizers. If the parents have a mix of a functioning allele and non-functioning allele, then they can have any outcome of children regarding their, where they stand for their phenotype. And the phenotype is basically just what we're calling their test result. So that gives you an idea of how this is passed down genetically. So this is probably the most technical slide we'll get into. What this is very simply, this is the liver, and this is how drugs leave the body. This is urination. On this side, we're looking at how a drug will ideally function in the body. When a person takes a medication, ideally they have the enzyme that's needed to break down that medication so they can just leave the body, so it can be urinated out. The problem we get into is the folks like Michael that they take a medication and they don't make the enzyme that is required to process that medication. So when it comes time to urinate it out, it doesn't happen because the medication's never been translated into, or just not able to leave the body. It hasn't been oxidized. The problem here is accumulation occurs. Basically, these drugs are loitering inside the body. They have nowhere to go. They can't leave the body as quickly as they should. And if you continue taking the drug, you have drug accumulation. This slide is really key. These are the major cytochrome P450 enzymes and the approximate percentage of drugs they metabolize. The one I want to focus on the most is 2D6, because this is a big troublemaker. A great deal of medications on the market, 25% are dependent on 2D6, and 50% of the population function differently than normal for 2D6, and that includes everyone in this room. 50% of us are going to have at least one non-functioning allele or one additional allele for 2D6. 2D6 covers a lot of the most commonly prescribed beta blockers, a lot of the most commonly prescribed opiates, and by far the majority of psychiatric meds as well. Our lab tests for all 5 of these, and together they cover about 60 to 75% of all meds on the market. If there's one of these that you remember that you want to walk away with, it's 2D6, because this is the real troublemaker. Or not to say the others can't be, but that one we see the most. This is a confusing slide, and I apologize for it. There's just a lot of information here. I'm just going to really kind of focus on 2D6 because that one is so major. So poor metabolizer has no functioning alleles. This is Michael. This is 5% of the population. So if you have 100 patients, 5 of your patients are probably going to be poor metabolizers. These patients will tell you when they take a medication that uses 2D6, if it's highly dependent on that medication, they are almost certainly to have an adverse drug event. Intermediate metabolizer, this is a huge percent of the population for 2D6. 36% of the population are intermediate. These patients won't necessarily be toxic, but they will have some degree of drug accumulation. So they may not necessarily get in trouble with drugs, but typically a lower dose would be appropriate. Normal metabolizers, we know, make up less than 25% of the population. And these folks can probably take drugs as made by the pharmaceutical company without issue. That doesn't mean they still can't have allergic reactions or side effects. What we're talking about today has nothing to do with allergies. That's separate. So you can still have allergic reactions to meds. And then rapid and ultra-rapid metabolizers make up about 3% of the population. And for these individuals, if they're taking an active drug, they'll have a lack of efficacy with the medication. So these are your pain patients that are coming back and asking for more higher doses of medications. A single person can have different combinations of cytochrome P450 results. So for one individual, Prozac can potentially be a big troublemaker for them. For another, they could be fine on one medication. So just kind of keep that in mind. A person can have different results for these enzymes. A big question for the physicians in the EDS group was asking, and for Dr. Forrest Tennant, a pain doctor in California, had mentioned this too, was a question basically if EDS patients, hypermobility and Chiari patients were more likely to have this issue than the general population. For our lab purposes, we only test people who are having medication issues to begin with. So we can only compare Chiari hypermobility in EDS patients to what is our general population for our lab, which is people who are already struggling with medication management. So I want to be clear, this is an informal study informal data that we looked at. It's not a proper study. But we looked at 203 patients, 94 patients from Dr. Henderson's office at Metropolitan Neurosurgery, and I think 109 from Dr. Posinki's office. And we'll take a look. So I'll go through each of these. All the orange folks here are Dr. Henderson's patients. Of the 94 tested, the percentage. And all the blue here are from our lab, which is, for the sake of this data, was about 21,000 patients. 7%, which is interesting, the numbers correlate pretty closely. 7% were normal for all 5 enzymes. That's a pretty low number. About 32% of his patients had 1 enzyme functioning differently than normal. 41% had 2 enzymes functioning differently than normal. About 19% had 3 functioning differently than normal. And what I'm really glad to report is a very, very small percentage, actually none for his patients, had any functioning differently for 4 or 5. If a patient did have 4 or 5 of these enzymes functioning differently than normal, they'd be extremely difficult to medicate, because you'd be trying to medicate someone who can't take 60 to 75% of all meds out there. So the good news is we don't see these folks very much in the population, but what we do see is a high percent that have 2 functioning differently than normal, which means they're going to run into potential problems with meds that use those enzymes. Very interestingly, Dr. Posinki's patients at George Washington University Hospital, pretty similar correlation here. We see about 5% of his patients normal, and pretty close here, about 47% of his patients having 2 functioning differently than normal, and then very few, if any, having 4 or 5 functioning differently than normal. So this just shows you, kind of putting it all together, we're seeing pretty average numbers. So our thought on that is, based on the data we have at the moment, it's fair to say that patients with Chiari hypermobility or EDS are not more likely to have cytochrome P450 polymorphisms than other patients tested with Genelex. That's not counting the general population, because most of the patients tested with us are having issues with their medication management to begin with. So it's informal, but kind of keep that in mind and kind of take it with a degree of a grain of salt. That said, knowing that so many people do have cytochrome P450 polymorphisms, testing should be given consideration when treating polypharmacy patients who are more likely to end up taking medications that use these enzymes. So Dr. Henderson asked me to put together a list of the most commonly prescribed medications to Chiari hypermobile and EDS patients. And this is a combination from the 2 prescribing physicians. And as you can see, these are probably medications that you're prescribing on a daily basis. And some of them we know are real troublemakers with 2D6, metoprolol, dextroamphetamine, tramadol, fluoxetine, carvedilol. So a lot of these meds can get patients into trouble if they're having these enzymes functioning differently than normal. So the next step here is what do we do about it? And that's implementing pharmacogenetics. And I'm going to just kind of walk you through what it's like working with our lab to do exactly that. So the hardest thing is assessing the patient for pharmacogenetic testing. Adverse responses to medications can take many forms. It really depends on what that medication does in the body and what it will do when it accumulates in the bloodstream. If a patient experiences symptoms immediately or within a few weeks of starting a new medication, this may be an indication of an adverse drug event. And the problem is, a few of these examples are things that you probably see all the time from your patients. These are things that you're probably dealing with in Chiari that are Chiari related anyways. So it's hard to determine when to test a patient for this. And probably the best way to go about it is on intake. The first time you see the patient, and say, have you had a history of difficulty with medication management? If they say yes, that's probably a good reason to do this. Or again, if they've just started a new medication and started to report one of these issues. But these are the things we tend to hear about most often from adverse drug reactions from patients. So for our lab, we send you a box that looks like this that includes everything you need to test. It's just a simple mouth swab. There's 4 swabs, completely painless buccal swab collection. A test requisition form, it requires a ICD-9 code. You check off the panel test, which is going to cover 60 to 75% of all meds. What's different about us as a lab is we're going to ask you for all the patient's current medications. And the reason for that is it will impact the part of the results that we send to you. And then you just mail that back to us. You just mail us the swabs and the test requisition form. This is what our results look like. The first part of the results is just going to have the phenotype. So we're going to say, okay, this patient's intermediate for 2D6 or poor for 2C19. It's basically a colored warning system. So red means this is considerable. You really want to be aware of this because there's potential for toxicity here. Orange means you want to monitor for this. It's not as severe as the red warning, but just be aware of some possibility for difficulty here with the patient. Probably the most important part of our results for your purposes is what we call our PharmD summary report. We have 4 full-time PharmDs, and part of their job is when we get the test results in, they will look at the patient's meds and put it all together, and we'll make suggestions for you based on their current meds. So the actual test result will show you the medications that were submitted at the time of testing, and then their suggestions if appropriate. So, and it's very straightforward. In this case, the patient's taking amoxetine, and we say, or Strattera, which has a black box warning for testing for the FDA. Strattera exposure may increase in 2D6 intermediate metabolizers. And then we say, here's what to watch out for. Monitor for GI disturbances, insomnia, increased heart rate, increased blood pressure, and tremor. If you're seeing these things, then consider decreasing dose or prescribe an alternate medication instead. We're not in cahoots with the pharmaceutical industry. We just mentioned other drugs that don't use that enzyme. So immediately, as soon as you get these results, even if you're not an expert in this, and we don't expect you to be an expert, you can start using the results, and you can prescribe alternate meds. And then we go down the list of meds where we might suggest alternates. So you can immediately start using our results without totally understanding this. As time goes on, you'll get very good at doing this, and you'll start prescribing meds that don't use these enzymes, and you'll kind of avoid this whole situation to begin with. Another quick thing that I skipped is a patient's genotype for this is not going to change during their lifetime. So a patient from the time they're born to the time they die this is going to remain the same. So it's a one-time test for life. Patient gets tested once and doesn't need to be tested again. So this is interesting. This is a breakdown of the 94 patients that were tested. Using our gene-drug interaction software, we found that 9% of Metropolitan Urology Surgery Group's patients got significant warnings. Keep in mind, these warnings are probably going to be almost exactly the same for your office because this is upon intake. When you're first seeing the patient, you're doing genetic testing, you're finding out what meds the patient's currently taking. So that by the time the patient gets to you, they probably already have 3 or 4 prescribing doctors where this is going on. So in this case, we're saying about 9% of patients have changes that we think should probably happen because they're considerable. The patient is probably struggling with those. 31%, it's just consider some changes here. They're not going to be as significant as this, but the patient may be experiencing them. And you'll see that, we see this very typically at this proportion. So expect to see the same type of data in your own office. So the way we come up with that data is using a gene-drug interaction software. We're the only company that makes anything like this. It's a cumulative gene-drug interaction software. So it's your average drug interaction software looks at drug A versus drug B, then drug B versus drug C. And what we're doing is not that. We're cumulative. We're looking at everything all together at once, not only the drug-drug interactions, but also the drug-gene interactions, and then multi-drug-drug gene interactions. To give you a little idea about this, the software is kept up by our PharmDs, so part of their day-to-day jobs to do are looking up studies and finding out about new drugs as they hit the market, entering those drugs into the software program. And right now we have about 2,500 drugs and metabolites. We back everything up with PubMed links and notes, so everything we say, it's not conjecture. We're saying there's been a study about this. We have data to it. So if you want to dig in deeper and find out more about it, you can. It's all there. Or if that's too daunting for you, you can just look at the red warnings and go that direction too. But you can go in as deeply as you want to on this. Significantly, the software catches a lot more interactions than other softwares can, about 34%, because it's able to identify drug-gene interactions and drug-drug-gene interactions. A normal drug interaction software simply can't do that. The software comes with the test results. There's no cost to your office to implement this if you're doing the testing with our lab. So basically, the question then is, once you get your test results, let's say the patient comes back 3 months later and you want to start them on a new medication and you want to know if that medication is going to be okay for them. They don't need to retest with our lab. No more money needs to be charged to insurance. It's just a matter of looking it up in the software, which I'll get into. So the beauty of this is it allows you as the practitioner to check for gene-drug interactions prior to prescribing new medications, and then the software provides alternate medications when appropriate. This is really significant for polypharmacy patients suffering from chronic conditions, as it reduces the potential for medication failures and allows you as the practitioner to focus on the patient's primary condition rather than treating adverse drug events. And I think this is really key because we can see for 9% of the tested patients with metropolitan surgery, they're going to have adverse drug reactions probably. And the problem is they're going to come in saying, I have this problem, but it's not going to be related to their condition. It's going to be related to what's going on with their adverse drug events from their medication management. So if you can get a handle on that, then you can focus on what's really going on with their condition and rule out the adverse drug events. So here's a very quick look at what the software looks like. It's really simple. You enter the name of the drug and the patient's test result. We actually enter this for you. So you just pull up the patient name to do this. And very quickly you can see that there's an interaction just because if the patient's a poor metabolizer taking fluoxetine, this would be the case. Interestingly, two of the drugs we talked about today, Pindolol and Midodrine, would have the exact same effect with the 2D6 poor metabolizer. Those drugs would go up in the patient's bloodstream, we estimate between 76 and 200%. So almost certainly the patient would be experiencing some accumulation and potentially some discomfort because of that. The beauty of the software is it's very easy to find an alternate drug. You just click on the name of the drug, you go over to alternates, you pick the drug class, and then the software will, and the beauty of this is the software will look at all of the patient's meds, all of their genetics, and do the calculation for you. It will find the best alternate medication available. This is an incredible time saver. This, instead of spending an hour trying to figure this out online or in books, the software does the algorithm for you. In this case, it gives a number of drugs that can be used as alternates. In this case, it was sertraline. And then when we just click on the plus button there, and what it does is it takes the fluoxetine out, adds the sertraline, and we see that there's no problem. Sertraline has no interaction for a 2D6 poor metabolizer. So sometimes the software can just be that simple to use. Patients, that's a simple example. It was one medication. Patients taking 10 medications, you're going to see probably a lot more interaction. So it can be a little bit more complex, but you can be very pragmatic about going through them one by one and finding better alternate drugs. Right now, it's covered widely by insurance. The trick to that is Medicare. Medicare covers 100% right now. That may change in the coming year. Private insurance covers it widely. It just varies by plan. And Medicaid does not cover the testing at all, so at this time we can't accept Medicaid patients unless they're paying out of pocket. One thing that's nice about our lab is we don't send patients to credit reporting or collections at this time, and we have good karma with patients for that reason. And just kind of to wrap up, I think one thing we learned today, or I learned today and from hearing a couple of lectures regarding Chiari is when a patient has surgery for Chiari, it's not necessarily going to fix them 100%. It might get them 70% of the way there. Their physical therapy might get them another 20% of the way there. And this is a piece of the puzzle too, in that it's not going to fix the patient's problems, but it's going to be some percentage of getting the patient, of helping the patient along as far as we can. And I think that's a good way to think about this testing, and to just, keep this testing in the back of your head, in your back pocket. So if you have a patient who's really struggling with their meds, think about this, because this may be the culprit and something to look into in order testing for. And if you're interested in testing, just let me know. I've got applications here, and I can hand you one, and you can fill it out today or later on. Thanks. Yes, sorry.
As with many tests, will any of the major testing facilities like Quest or LabCorp, will they do this testing and send it out if you request it?
Absolutely, yeah. LabCorp does this. So if you're in a hospital system that's already working with LabCorp, you can do it through them. There's PGXL that does a good job. There's AssureRx as well. Those are the better labs. There's a lot of not so great labs. There's a lot of labs that are just have come out of the woodwork to make money on this that you have to watch out for. But I think AssureRx, LabCorp, PGXL, those are going to be good labs to work with. None of them provide the gene-drug interaction software, though. We're the only lab that provides that.
And the other comment, many physicians use Hippocrates, and they've started, as of their last updates, to be listing all the cytochrome sensitivities in every medication you bring up almost. They didn't do it for mitogen for some reason. You said there might be some issues, but they said unavailable, it's unknown.
Yeah,
but for many of them, they listed.
It's a manpower issue. They probably just need more time to do that because it's pretty involved, because you basically have to have a PharmD updating that software regularly, which we have, so they'll get there in time.
And very interesting. Are there other enzyme systems that are being investigated for drug interactions?
Yeah, absolutely. In fact, we're adding a number of tests. I think we're going to have 39 new tests this year. So we're really expanding that. There's the UGT pathways that morphine uses, for example. So there are absolutely other pathways where this could be an issue. These are I just call them troublemakers, the biggest troublemakers, but there are definitely other ones. And basically, as the genetic technology gets better and there's more studies, a lot more of this will become available too. Yeah.
Fascinating. Any other questions? Dr. Bolognese?
Yeah, if the insurance coverage for this test is going to change, how much is the current out-of-pocket expense?
Sure. If a patient just pays out of pocket, not submitting to insurance, right now with our lab, it's just under $1,200. You'll probably see that change very quickly. It'll probably, don't quote me, but you'll probably see it get in the $800 range in the next couple of years, because the technology is just getting better, but that'll change soon. Yeah.
Other questions?
Real quick,
Awesome.
on that note, so it's $1,200. Who pays that? The patient? Because I guess as I'm sitting here, I'm trying to see sort of what you're offering, and what I think you're offering, which is unique compared to a number of the other testing companies, is really the software. The software that's searchable, that really helps the physicians figure out, if my patient can't take this drug, what else could they take? But that software is for the physicians. You see what I'm saying? So I guess I'm trying to understand why the patient is paying $1,200.
Sure. I'll explain that. And I'm sorry, because I didn't mention it just for time constraints, and usually I have it in here. So we send the patient a wallet card with their results that they can take with them anywhere they go. It just shows their phenotype. It doesn't have any suggestions for changes. But the patient also gets 90 days free software access. So if the patient is interested, and we have a lot of nurse practitioners, go to the TMS conference or EDNF conference, and you have patients who are nurses who are all over the software, because they get it and they understand clinically what it means. And they have the same access that you have as a practitioner, but it's totally separate. They can't see your patients. Obviously, theirs is just for them. For a patient, it's very low cost. It's $24 a year to keep it going, so it's $2 a month. Yeah, and there's no cost to your office to ever make this available. So if the patient has private insurance or Medicare right now, their cost will be minimal for this. Yeah.
Dr. Kula, you had another comment?
The question was if the patient allows you to have access to it. If they give you the card, in other words, if you see a patient that's had the testing done, you can access the software in their with their findings on it, if they give you a code? Is that the way it works?
Absolutely, yeah. Well, sorry, you could access their copy of the software, yes.
Yeah.
So they could walk into the office and pull it up. And in my suggestion to patients is, let's say they go into their GP's office and the GP has never heard of this. 82% of doctors have never heard of the cytochrome enzymes. I suggest to the patient that they bring a tablet computer or laptop with them and look it up themselves. So when the doctor says, here's your prescription for metoprolol, they say, hold on 1 second. They look it up and say, you know, instead, could you give me atenolol, which Dr. Rowe smartly prescribes over metoprolol because he avoids the whole cytochrome issue just by prescribing one drug over another. So it gives the patient a lot of power to take action on this if they're so inclined.
The last question is, can physicians access the website for questions themselves? Like if they want to look up mitogen, is there a P450 indication for that drug?
Yeah, there's a free 30-day trial, so you can go to our website and just try it out for 30 days. Also, which will really be helpful to you, on the patient's card and on our test results, you can call, and any physician here can call, whether they're testing with our lab or not. You can call our 800 number and speak directly to one of our PharmDs. So you can just ask them. You can say, does Midodrone use the cytochrome enzymes? If so, what's an alternate drug? And they'll give you that information right over the phone.
The 30-day trial, that means after 30 days, the physician might have to pay for access to the website or not?
Yes, for the software. So if you're not doing testing with our lab, you'd have to pay for the software, which is
what is that, Ron?
$199 a year. Then if you're doing testing with us, then there's no charge for the software, yeah. Because honestly, the way we make our money is through the testing itself. That's how we stay in business, is the actual lab test, not the software.
Well, this is fascinating. Thank you very much, Dan. I think you all agree that we've had a very successful day focusing on the comorbidities. And I think what I've carried away is the interrelatedness of so many entities in so many different ways. We've learned about instability of the neurovascular system, instability from a mechanical point of view, instability from the point of view of joint capsules, of connective tissue. Now we've learned about metabolic variations in the system, and we've learned about the far more complex central pain mechanism regulation, about dysautonomia, and then we've learned about secondary Chiari malformations, be it in pseudotumor or related to tethered cord syndrome. So there's been a wide variety of related conditions, which makes me think that the idea that Chiari malformation, for whatever that term is, Harold, excuse me, is anything but a simple entity. It is a very, very complex entity, and I would suspect that 10 or 20 or 30 years from now, people will say, you know what they used to call that? They used to call that a Chiari malformation. My goodness, there's this type and that type and the other type, and they just lumped it all together. So that is progress, and we've learned about physical therapy to address some of the issues. So I would like to throw the floor open to comments and questions that people may not have had an opportunity to ask, or comments that they would like to make about any aspect of a previous presentation. Fraser, you had some comment that you wanted to make?
Thanks, Ulrich. I think Ulrich is the best moderator in the world. But, just a comment. I missed the very end of the lecture on tethered cord syndrome, and I wanted to corroborate what Cormac was saying. But by the way, Cormac was a medical student when I was at Georgetown, and all of the students came through and hung around with me mostly. He was the finest medical student I ever met, and I no doubt that he'll be chairman at whatever program is lucky enough to have him. And so I'm really delighted you're here, and whenever you speak, I listen. I did want to slightly say, however, that Cormac was addressing more pediatric occult tethered cord syndrome. And there is an issue with the difficulty in getting a good history and physical exam on pediatric patients. In the adult patient, however, when they present with a very good history of problems as a child of enuresis until age 12, and then suddenly at age 20, they went from being a Class A athlete, and now they're having difficulty walking 50 yards, and they're having severe low back pain, and you examine them, and they have marked leg weakness and sensory deficits in the lumbosacral dermatomes, and you perform a urodynamics, and it's positive for a neurogenic bladder with detrusor sphincter dyssynergia. That is highly specific, highly sensitive for tethered cord syndrome. So in this respect, in the adult population, tethered cord syndrome is definitely a clinical diagnosis. And we look to the radiology and with the hopes of finding a low conus, but it's often not there, especially in the EDS population. We look for fatty phylum, terminal syringomyelia, scoliosis, abnormalities of the CSF space, and spina bifida occulta, and they're all soft findings. But I would really ask that everyone listen to the patients, and they will tell you their diagnosis. And when I operate on a tethered cord syndrome, it's absolutely clear and evident to anyone who listens what the problem is. And you don't need to see it on the MRI. So I want to, on the one hand, endorse what Cormac was saying about the pediatric population, but on the other hand, say, please listen to your patients when it comes to tethered cord syndrome in the adult patient. Our last comment is, we made this book for the colloquium last year, and we're going to do another one this year. It reads very, very well. And so I hope everyone's going to get the chapters edited. They'll be sent to you in Word. You have an opportunity to edit them, and then Dr. Batzdorf and I will also edit them, and we'll turn out a book like this, hopefully in 6 months. Thank you.
Thank you, Fraser. I would have to say that my greatest worry about getting that detailed history is whether the physician's assistant who is going to be running our offices will be able to do that as well as you and I. What is the answer?
Let the patient do it themselves.
Well, but
you can see, that's one of the great things about what we do. And that's we send a 7-page thing to the patients online. They can fill it out, and so all of the questions that you want the answers to can be then looked at before you've seen them, number one. And number two, they'll be available for any database that we want to
True, and yet I disagree. I can't tell you how many times, including just last week, a patient will give me a detailed history, and just as they're about to walk out the door, I had this patient just last week who is an adult with a tethered cord syndrome, said, you know, I forgot to tell you something. Actually, I was in physical therapy, and I had very vigorous exercises, flexion and extension of my back, and it was within weeks of my doing those exercises that my urinary tract symptoms and my gait disability started. Probably very important in terms of stretching her neuraxis. And that would never come out in a questionnaire. And I've had...
Well, I'm not saying you shouldn't talk to your patients. I'm saying the electronic medical record is not the problem.
Well, it's not the answer either. All right. On that happy note, I'll turn it over to Dorothy. I want to thank you all, the participants, for coming and for presenting a splendid program. Thank you all so much.
So I too want to thank everyone in this room. First of all, Rick, for being the leader of our group right now for the Seaboard. Thank you, and you're doing a magnificent job. Dominic is actually our vice chair. We have a veterinarian, which I think that's kind of unique for society as the vice chair for our group. I want to thank Paulo for helping out. He's not our official IT guy, but he always pitches in and helps, so thank you. And then everyone who came here today, this is, we're not an exclusive club here. In fact, we really want to be inclusive. So when you go out and talk to your friends, or if there's somebody you think would be interested in being here, we want them to come. This is a place where we can share ideas under a tent, and hopefully you as physicians get more out of this than we even get as for the patient end. You know, it's really a place to make new territory happen, and it's happening, and I'm watching it, and I'm excited because it's really happening. But don't be afraid to share what you learn here, or just the thoughts. Get other people thinking about it. So I hope when you go out from here, ask some of your colleagues, ask people at the CNS, you know, what do you think about that? It's great, because we'll get everyone thinking, and that's the goal. That's the goal, to get everyone thinking about this.